haven't been on board with ARTnet for as long as Roz has. I think it's
Sorry,
about
Kathy.
a year now that I've been a physicist, along with Dr. George McGill, who's based up in Queensland. But it is a super interesting time to be involved with ARTnet. As Roz captured, it's really this sort of overarching network that allows us to connect across all nuclear medicine sites. It's really promoting not just involvement of those sites in clinical trials, but very much a uniform and consistent approach to the data collection for those trials. And as we move into this era of new generation PET scanners, digital PET, and in particular, as we're talking about today, the total body PET, it raises some really interesting questions. So yeah, I'm going to be talking a little bit about the actual credentialing process that Roz was referring to, which I'll refer to as the site assessment. So ideally, we like sites to perform a site assessment for credentialing prior to enrolment in the clinical trial. And this, as Roz mentioned, are trials largely involving PET, but also we're branching out into quantitative SPECT, and that's been very largely driven by the interest in lutate therapy. The site assessment process through ARTnet involves imaging of the IEC body phantom, which I'll refer to as the ARTnet phantom, and that's done following very strict filling and acquisition protocol, and then that DICOM data gets sent to a core laboratory for a consistent approach to analysis. If data are deemed quantitatively accurate, the site will be passed, and that certification is generally valid for a period of 2 years from ARTnet. However, if sites are undergoing, any changes, significant changes in hardware or software, it may need to be revalidated during that time, just to make sure results for patient studies remain consistent throughout that duration. So we currently have 4 ARTnet phantoms that are in constant circulation around Australia, and there has been discussion about branching out to New Zealand as well. One of the things that's come up recently is the delay that is introduced if we fill the phantom with a long-lived isotope, things like lutetium, for example, or iodine-124. So to try and get around that, we've developed what's called the ARTnet insert. So you can see an image here of the IEC body phantom. As I'm sure most of you are familiar, it's got 6 fillable hot spheres of different diameter, which allow us to assess things like contrast recovery coefficients and look at partial volume effects. And typically, according to the NEMA protocol, this would be filled with a warm, uniform background as well of a different concentration of activity. But that means that when we have a long-lived isotope, most sites are having to store the phantom, which is quite large. It's getting up to 10 litres. They have to store that for quite a period of weeks until it decays and can be safely disposed of. And we were finding that was really impacting the circulation of these phantoms and getting sites assessed and certified. So we've introduced the ARTnet insert, which you can see here. It's about 500 ml volume. It fits into the existing IEC phantom. And we've currently got 11 of these inserts that have been manufactured. They can be shipped to sites independently to fit into an existing phantom, or they can also be shipped with the ARTnet phantom itself, and I'll show you in a second what that package looks like. And it's still being refined a bit further. We found some sites have very slight different dimensions, Z dimensions of the phantom if they're using their own in-house phantom. So we're looking at things like a bit of a flexible spacer for this insert, just to make sure there's a bit of give in which phantom it can be accommodated in. But this has been a great introduction. It means that sites only have to store a very small 500 ml volume on site. Otherwise, the phantom can be emptied and shipped off to the next site waiting to do their site credentialing process. So it's been quite successful so far. For sites that are doing the credentialing process, you will receive a large transport case from ARTnet, and inside we've got everything that's required to perform the site assessment. And this has been sort of years in the making of doing many of these experiments at different sites, and we've slowly refined it over that time. So you can see the IEC body phantom is supplied. We have a bottle with an engraved marking for the specific volume that's needed for the ARTnet protocol for filling the phantom correctly, and all the other bits that are required. And then there's a second layer underneath that where the ARTnet insert and the Perspex spacer are contained as well. It also, of course, comes with instructions. So we feel quite strongly that all sites are performing an identical protocol when it comes to filling the phantom. We follow the NEMA instructions. It gets filled in an 8:1 sphere to background ratio. Obviously, that's a bit different if we're using the insert, which I'll talk about in a sec. All sites follow the same protocol. They're all required to fill out a worksheet which captures all the important information, allowing us to assess the phantom data back at the core laboratory. And as I mentioned, if you're using the insert, you won't be filling the background of the phantom either. So it's a slightly different protocol, all contained within the one document. And that's determined by really the trial coordinator, or ARTnet will be able to advise which protocol you'll be following. And it will largely depend on, obviously, the isotope that's being used. In terms of the analysis at the core laboratory, it's following the NEMA and U2 documentation on image quality assessment. And so we're reporting accuracy of SUVs in background, or in the case of the insert, in the actual insert itself. It's designed so that it's of a size that doesn't suffer from any partial volume losses. Variability, contrast recovery, and scatter as well. So sites essentially either have a pass or a fail, or I say sites, but it's really scanners, essentially have a pass or a fail for a given isotope. And that's largely to date been based on whether or not the SUV is 1 with a 5% threshold acceptable. But there are more and more, we're getting interested in using the data a bit further. So for example, the iFirst trial that Ros mentioned, looking at I124, that is, I know, using recovery coefficients based on those hot spheres that I mentioned, to look at applying partial volume corrections to estimates of lesion dosimetry on the patient baseline data. And that is used to determine whether or not those patients can reach a certain dose at therapy and hence participate in the trial. So there is a lot of information in the phantom. There's more than just a background measurement of 1. And I think now we're at a stage where we're really interested in capturing that information and utilising it to take us down this path of harmonisation. So I'm really excited to hear what our guest speaker, Joyce, has to say about the European experience in this. I think we're sort of just on the cusp of exploring it here, but I think ARTnet gives us a fantastic framework to do this. We have the network in place, we have the process in place for collecting that data, and now it's a matter of really getting down to those comparison studies. And look, it's been very interesting having the Quadra on site. You know, I know our clinicians feel like you can't compare SUVs to what we used to see. But there's certainly a lot of things we can do to look at harmonising data with standard PET-CT scanners. And it may be that involves dumbing down data, so folding the matrix, adding Gaussians, smoothing, but also, of course, being very aware that for protocols, imaging protocols for clinical trials on this new total body scanner, you know, we need to be aware that the administered activity and acquisition times are not what we would normally be dealing with at other sites. And when we want to make data noise equivalent, that's certainly going to come into play as well. I do think it's really important for anyone thinking of doing clinical trial investigations on the total body scanner as well, just to bear in mind that there's a really large range of different options that are available, and certainly very accessible on the scanner. Whether it is the acquisition mode, so a static acquisition versus flow motion versus a dynamic acquisition, whether it's utilizing just the standard total body field of view, which on this scanner is typically vertex to mid-thigh, or whether you want to go down to feet. The high sensitivity versus ultra high sensitivity mode, which takes into account the angle of acceptance. There's things like deviceless gating and onco-freeze, which is a form of motion correction. There are other options in the software, such as what's called the smart framer. So perhaps if you're doing a clinical trial on brain imaging only, this is a total body scanner. It's obviously acquiring the total body, which is all in the field of view of the scanner. You don't have an option, but you can set it to automate using AI, reconstructing a certain region only. So for example, just brain, if that's all that is required for the trial for review and so forth. Also, the CT component is so far unexplored here, but this scanner is very new, and I think it's going to be very important in the clinical trial context for dose reduction. We know with the introduction of iterative CT reconstruction, the doses are largely reduced, but we've also got the tin filter available on this scanner as well, which offers another very significant dose reduction as well. So if you are, thinking of performing research, I think it's worth keeping in mind there's a lot of new aspects to the scanner. There is, of course, the harmonization aspect about making the data comparable with other sites if that data is being pulled together. But there's also the aspect of getting the most out of this scanner and what it can do, and it's hugely flexible. So it's very exciting to learn about this. And as I mentioned, very exciting to see what's been happening in the European centres, where they're already dealing with integrating this data into comparisons with other sites and other generation scanners. So just very briefly, this was the first extended vertex to toes scan from the new Quadra, and it looks absolutely beautiful. This was a nice example of a patient who came in just the other day for an FDG study, and you can see 150 megabecquerels at 8 minutes. That's since been reduced to a standard clinical protocol of 5 minutes. But the nice thing here is you can look at a comparison of a couple of prior scans just a few months earlier on 2 different systems, including the MCT, which is the previous generation, just a standard time of flight PET-CT, and the Horizon as well, which is at a different site. And really just comparing that data has, you just see so much more with this scanner, and it raises issues, as Roz said, about pooling data where we're looking at SUV max in order for patients to be eligible for a trial and so forth. It really does become a lot more noticeable on here, the resolution improvement and the contrast and just everything about the image quality, really. In terms of site assessments, we've already done some work on the total body PET here for F18 gallium I124, which you can see was done using the insert due to its 4.2 day half-life, and also copper 64. And these are all done to continue on using this scanner in clinical trials that were already involved in here at North Shore. But certainly any trials taking place on the scanner, we'd be promoting ARTnet certification for that specific isotope. So just to wrap up, I think moving forward, we would encourage any trials to be in touch with ARTnet for discussing the trial protocol as well as certification. I think it's really important to keep in mind, as I said, the flexibility of the acquisitions and the reconstructions and all the different options that are available, and it's worth discussing, certainly with people like Yorgos, whether or not the trial protocol is really suitable for this scanner or whether modifications would be advised. And there's a lot of work that needs to be done and is starting to be done to look at the harmonization. And it's going to be really interesting to see how comparable we can make the data to the other sites with standard PET-CT. So I'll stop there